into those things. What are those waivers and what are they being filed for it? As we mentioned about that, there are multiple elements to it. Ultimately, all boils down to giving the states the authority to do things outside of the federal programs being approved under Medicaid. Again, improving access to high quality centers for better outcomes, promoting efficiencies, promoting some transparencies in the context of healthcare services and delivery altogether too. And once the waivers are being submitted by the respective states, CMS performs a case-by-case review of each proposal to determine whether its stated objectives are aligned with those Medicaid. And the CMS also considers whether proposed waiver expenditures are appropriate and consistent with federal policies, including the degree to which they supplant state-only costs for existing programs or services, and should be supported through other federal and non-federal funding sources. On March 14 of 2017, Secretary Price then and then the CMS Director CMI Verma sent a letter to the governors and explaining the changes or small tweaks, as we call it, to the 1115 processes, especially on the approval side and then the kind of innovation and creativity side. Basically, we want or the administration wants to have the waivers to be more transparent, efficient, and less burdensome for the states. And initially, or continues to be, a somewhat of a slow process. And I think it's no secret that current administration wants to put out another program, as we mentioned loosely, we'll call it a Trump care. They want to have something in place before the next presidential elections. For that reason alone, if you think about it, it's going to take about a year to implement it, and it's going to be a year to procure and fund it. So that day, as you can imagine, it pretty much backs into today. So we are going to see some very fast movement in that space of approvals. So given the fact that historically it took some time, but I think that we're going to start seeing some fast track approval of the waivers and the demonstration projects. And more consistently evaluating and incorporating state requests for specific waivers. Once again, we believe that the Indiana HIP model will be kind of in a way replicated by several states. As we mentioned, that Michigan has done a somewhat quasi implementation on the Health of Michigan. So will Kentucky, as we speak, that we believe their 1115 approval is imminent. And we're also seeing other states like New Hampshire and Pennsylvania evaluating a similar type of a Medicaid expansion like programs, but encapsulating and covering the Medicaid population as well. So use of the existing 1115 authority to review and approve innovations to build on additional services. Alternative benefit designs. We believe that there will be other type of forms, call it a skinny plans or narrow networks. I think that 1115 waivers, we're going to start seeing some states basically opening up to non-essential health benefits compliant, ACA compliant health plans. More maybe pervasive use of consumer-directed health plans with health savings accounts like features for both on the individuals of all income levels, not just for the Medicaid expansion population. We're also expecting to see some employer-sponsored health insurance programs to be partly engaged. As you all know, that during the last few months of the Obama administration, the CURES Act was passed by a unanimous consent, which enabled the health reimbursement accounts, which we will commonly refer to as the employer's defined contribution, to be another form of funding for the individuals getting their coverage on the individual market. So possibly the minimum wagers or part-timers may qualify in the debt program that their financing could be partly funded by their employers. We're going to start seeing other type of kind of, again, as I said, non-essential health benefits, perhaps for a different type of programs for the high-risk populations and maybe high-risk pools. I think we're going to see some potential demonstration in that area as well. So those are the few areas that we will be seeing about this thing. And then possibly in the non-emergency transportation benefits, we're already hearing from some of the innovative states, in fact, using, for instance, Ubers as a means to extend the some of the Medicaid benefits altogether too. So CMS will work toward providing additional time for states to comply with the Home and Community-Based Services Rule, commonly referred as the HCBS rules. And CMS will be examining ways to improve engagement with states on the implementation of HCBS rules, including greater state involvement in the process of assessing compliance of specific settings. States may make managed care capitation payments for individuals with institutions for mental diseases in stays of 15 days or less within a month. So the next slide is at the CMS Information Bulletin. In fact, there's a slide was recently added with my colleague in here, Trevor. Brian Niels was basically issued another a detail about how the specific improvements can be reviewed through monitor under the 1115 waivers. So we're expecting a continuous guidance about the type of innovative programs that the CMS is looking from states to submit as an 1115 waivers. CMCS's Information Bulletin per Brian Niels. CMS will revise the demonstration template to streamline and simplify it, and they will remove the duplicative informations, and this is all towards the faster implementation and faster approval of the waiver programs. And the CMS also intends to work with each state to develop a timeline for the approval process to include a regular schedule of meetings. This will help to ensure states understand the information needed to facilitate the negotiations during the approval process. So the operational benefits, as expected, is again, as I said, expediting, supporting, and separating. In good faith negotiation, the timely approval using the following strategies. CMS will develop parameters for expedited approval of waivers under similar to those approved in other states, while preserving administration discretion of approval, recognizing that each state is affected differently. Demonstrations that fall within the parameters of presumed to be consistent with the statutory requirements, that they promote the objectives of Medicaid statute. CMS will also provide technical assistance to states to ensure timely identification of elements of a proposal that might preclude the use of expedited approval procedures. When possible, CMS may approve the extension of routine successful waivers up to 10 years. There's a lot of wording, by the way, informally has been discussed about the Medicaid innovation grants. We believe that some of these 1115 waivers, let it be on the Medicaid, or some might be tangentially touching the 1330 waivers as an enhancement or modification to the ACA implementations by those states under the Medicaid expansion, whatnot. The innovation grants are going to be available, and there are additional guidance from CMS, especially about the use of MMIS modularity acts altogether too. So we're expecting to see a lot more kind of flexibility and the opportunity to streamline the existing Medicaid implementation, both on the state sides or on the MCO sides. FastTrack for reviewing proposals from states to reauthorize longstanding policies with proven outcomes. This streamlines the federal review process, again, as I said, to make it more streamlined, designed to expedite the review process. And CMS will remove the requirements that states need at least one full extension cycle without substantial program changes. This change means that at first extension, the states will be eligible for FastTrack if the demonstrations meet the other criteria. And in some cases, if the state and CMS agree, extension requests will be segmented to allow for the approval of routine, non-complex waiver and expenditure authorities on an expedited time frame. And while more complex waiver and expenditure authorities will be considered under traditional Section 1115 waivers. Let's go to the next one. On the topic of promoting transparency, a state will be made aware of the demonstration approval process from beginning to end, and there's sufficient time in between approval and implementation of the demonstrations. So CMS is expected to continue to offer technical assistance. As I mentioned, there are some elements of MMIS modularity conversations around the 1115 waivers. We'll post and share transparency review checklist used to assess whether a request meets transparency requirements. CMS will share a working list of open issues with states, and CMS will work with the states on development and demonstration specific timelines. CMS will implement more formalized team approach to better and efficiently coordinate the federal efforts. If action requires a concurrent actions across CMS where possible, CMS will work to complete all actions on the coordinated and efficient time frame that will be developed with the state and facilitated with the regional offices. CMS will work with states to determine whether other federal Medicaid authorities under the Section 1915 waivers may be available instead of or in combination with Section 1115 authority in order to meet the state requirements. CMS will also expect it to work with states to identify the other federal funding sources may be available to support efforts already underway. And CMS will encourage early discussions about expectations for demonstrations and state capacity to procure and report required data and conduct evaluations. The current budget neutrality template and budget neutrality policy are available on the Medicaid.gov. And the CMS will standardize the budget neutrality to clearly state which population services and costs are included in the budget neutrality agreement, and whether the state's historical trends or the present budget trend rate was used to project the growth in the final agreement. The final bullet point in here is the 1115 monitoring and evaluation. Once again, then the target is the monitoring and evaluating resources, improve and standardize measurements, strengthen the capacity of CMS to implement the mid-course corrections, and produce and better understand the impacts in form of through Medicaid policies. At this point, I will flip it over to a little bit on the software.